Good evening and welcome to another edition of our ongoing webinar series. And we're going to talk about prenatal pediatrics and postnatal pediatrics, but specialty care here. And to introduce our panel, please welcome Anna Penn.
Hi, I'm Anna Penn. I am the Director of the Division of Neonatology in the Department of Pediatrics. And I want to welcome you all this evening. Thank you for joining us. And I have a great panel of people to speak with you tonight about some of the special programs that we have here at Columbia. Simpson, who's the Chief of Maternal Fetal Medicine and the Hillary Rodham Clinton Professor of Women's Health. She's also the director of the Carmen and John Thain Center for Prenatal Pediatrics, which you'll get to hear more about. Our next panelist is Ganga Krishnamurthy, who is the medical director of the Milstein Family Infant Cardiac Unit and is the Garrett Isaac Neubauer Associate Professor of Pediatrics. And our next panelist is Thomas Hayes, who is a new assistant professor in neonatology who focuses on precision medicine, which you'll get to hear about. And then last but very much not least, Donna Garey, who is the medical director for the Neurodevelopmental NICU Follow program and assistant professor of pediatrics and neonatology. So once again, welcome, and we'll have Lynn kick it off.
Well, wait, Lynn, before you get started here, let me just do a couple little quick housekeeping things here. Sure. I want people to realize if you go to the Q&A section down at the bottom of your screen, you can submit some questions and we'll try to work those into our answers in our webinar tonight. Also, this is all being recorded so that you'll be able to refer back to it. It'll be up on the Columbia Children's Health YouTube channel. And finally, there will be a handout of sorts, sort of summarizing all of the major points I think that we will be covering here tonight. So with that said, Lynn, if you would start us off. Oh, let me add one more thing, is that I've asked the permission of all of our panelists to address them by their first name. That's not to be disrespectful. That's to make it a little more conversational for everyone. So Lynn, why don't you start us off and tell us a little bit about what you're doing, your Center for Prenatal Pediatrics.
I'd be happy to. Thanks, Max, and thanks, Anna, for the introduction. As Anna said, I'm the Division Director of Maternal Fetal Medicine at New York Presbyterian Columbia University Medical Center, and I really have the privilege of working with some of the best clinicians and leading researchers in maternal fetal medicine, or clinicians, subspecialists that deal with high-risk pregnancies. And at our institution, we really developed areas and centers of, clinical excellence. One of those is our Mother Center, which deals with pregnant women that have, medical and surgical conditions, or particularly patients that might be at really high risk for preterm labor and preterm delivery. That will require, the services of my colleagues in the neonatal intensive care unit. And then we have, which I'm very proud of, is the Center for Prenatal Pediatrics. And it was a concept of Mary Dalton, who is the chair of our department. When she first put the word prenatal pediatrics together, people were like, you're not pediatricians. Why are you using that word? But it really did help focus all of us on the OB side to really recognize that we're dealing with two patients, both the mother and the fetus, and many pregnancies are very complicated, due to fetal anomalies, genetic syndromes, complicated twins, cases that need in utero therapy or need really specialized therapy once the babies are born. And in the Center for Prenatal Pediatrics, that's where many of us work together. It's a multidisciplinary approach to care of our pregnant patient and their unborn baby. And I think it really is a place where we can, get the diagnosis right, get it early, get multidisciplinary input into how to best manage that pregnancy, when to deliver, how to deliver, and how the baby will be managed. It's such an exciting concept to have that center in existence. And I think it is one of the centers that makes Columbia really special in managing high-risk cases.
So Lynn, we're going to dig into that a little bit more, but in just a minute. But Ganga, tell us a little bit about your area of expertise.
Thank you, Max, and thank you, Anna, for your great introduction. My name is Ganga Krishnamurthy. I'm the medical director of the Milstein Family Infant Cardiac Unit at New York Presbyterian Hospital and Columbia University Medical Center. I want to start off by saying how different our unit is. It's a dedicated 17-bed infant cardiac unit, which is very different from your usual scenario in cardiac intensive care units, where generally across states and the world in general, what you would see are babies who have heart disease, or anybody who has heart disease would be taken care of in either a pediatric intensive care unit or a dedicated cardiac intensive care unit. So what that would mean is that if you, by definition, were born with a heart disease, you would be in one of those units. Now, these units were designed, especially the dedicated cardiac intensive care unit was designed for one specific purpose, if I might say so, is to help the surgeon out for his comfort or her comfort, to have all the babies or all the children with heart disease housed in one specific place. So we decided at our institution several years ago that if we were to do everything from scratch, start everything from scratch, how would we do it? Would we do something to benefit the surgeon, or would we design a unit to benefit our patients? So we decided to do a couple of things. Instead of making our cardiac intensive care unit bigger and bigger, we decided to develop a program where the bigger children would be taken care of in a dedicated pediatric cardiac intensive care unit. And if you were a small baby, a neonate with heart disease, you'd be taken care of in a separate unit. That was the infant cardiac unit. So about 3 years ago, we opened that unit up. It's a 17-bed unit just dedicated purely to the care of newborn babies born with heart disease. And so in that unit, we have, as all of you know, it's not just the structure where you take care of babies, it's the who are the people who take care of these babies. And we have an extraordinary team of, extraordinary multidisciplinary team that I'm so privileged to work with, starting with physicians who are trained in this, nurses, nurse practitioners, faculty from other disciplines. So this is a model that is not seen anywhere else in the United States, and that we are very proud of, and that we think is the right approach to take care of babies with heart disease. Thank you, Max.
Great, very good. Tom, tell us a little bit about precision medicine, but don't tell us everything, because we've got to come back and go into it in a little more detail.
Okay, thank you. So my name is Tom Hayes. I'm a physician scientist working as a neonatologist here at Columbia. And I'm interested in bringing genetics and genomics, both the diagnosis as well as the science, into neonatology. So genetic diagnosis has really transformed the way a number of fields in medicine are practiced, particularly cancer. And it's just beginning to percolate into the neonatology. And I think neonatology is a field that is really ripe for it. So, for example, if you're looking at diseases of the heart, that affect babies in our cardiac unit, there are hundreds of genes which can lead to congenital heart disease. Kidney, the number of seizure disorders, it's over 1,000. And if you look at recent publications describing the genetic causes of neonatal diseases, most cases are unique, meaning that they're seen only in that patient. And the presentations of whether a fetus or a newborn, it's often very non-specific. It could be simply a structural malformation of the heart, or metabolic illness, or critical illness. And it's something where having a fast diagnosis is very important. So I'm interested in studying how we can use the new techniques in genetic diagnosis to improve newborn care. Columbia is a wonderful place to do that because we get referrals, like Lynn discussed, to the Center for Prenatal Pediatrics of pregnancies affected by anomalies or disorders. We have these referred to our cardiac units. We care for very complex cases. So I think it's a wonderful place to try to bring precision medicine into care and then to disseminate our findings so that we can help the community.
Great, and we will in fact dig into that a little bit more later on this evening. And let's go to Donna. Tell us about your center there of developmental issues in newborn care.
Thank you, Max and Anna, for the introduction. I am Donna Garey, and I'm the medical director of our NICU Follow-up clinic. And our clinic is unique in that we follow the developmental progress of all of our high-risk infants after they're discharged from the NICU. What that means is for many of our preterm infants, also many of our cardiac infants and other infants with other surgical issues, we follow them up after discharge. Typically, we see them around 6 months of age and then up until 3 years of age. We do special developmental testing to check their cognitive skills, language skills, and motor skills at every time point. Our clinic, we do have several neonatologists in clinic, as well as a behavioral and developmental pediatrician and a neuropsychologist to help do these evaluations. And based on the evaluations, we make various referrals to physical therapy, occupational therapy, other specialists to make sure that the children are receiving all the services they need and all of the other specialty care they need in order to reach their maximal development.
Terrific, and we will in fact get into this a little bit more. I think that what's interesting here in my dealings with pediatrics and pediatricians over many years, the one thing that they all would tell me is that children are not small adults. But this group in perinatology and neonatology takes it kind of one step forward or one step beyond that, or 2 steps beyond that, saying newborn infants are not small children and premature neonates or preemies are not small newborns. So everything is a little bit different depending on what we're talking about. So the other area that kind of, as you said, Lynn, sounded like an oxymoron in a way is prenatal pediatrics. And tell me what are some of the issues that you deal with, and how do people and women and mothers to be then get referred into your group?
We're very fortunate in the Northeast, or at least where we practice in the tri-state area, in that many of our surrounding obstetricians and colleagues actually do a very good job in their offices and in their smaller community hospitals, recognizing pregnancies that are high risk. So, a patient who doesn't get their care at Columbia to start, might be diagnosed with a fetal anomaly like a congenital heart defect that we were talking about already. And I think many of the local, obstetricians recognize that those babies are going to be probably better served if they deliver at a big hospital with, all of the extra services that are going to be required. So they get referred in to the Center for Prenatal Pediatrics, one for confirmation of the diagnosis. And certainly they're often right. Occasionally we'll get a patient where we actually can tell them, actually, look, everything's normal and your baby's okay, and you actually don't need to transfer your care and deliver here. And that's always a good feeling. But certainly, for a major heart defect, we're going to confirm that diagnosis. And in the Center for Prenatal Pediatrics, we're really fortunate in that, we have our genetics team there, we have our pediatric cardiologist there, so they can get their ultrasound to make sure the rest of the baby is normal. If they need any genetic screening or diagnostic testing, that can be done in the center. And they can get their fetal echocardiogram, with the pediatric cardiologist, and they can get all of that really in one day. And depending on how far along they are or how serious the issue is, they can even see, the cardiothoracic surgeon, that would do the repair after the baby's born, and after that baby, primarily after the baby's born. So I think, the prenatal pediatrics part is really getting the diagnosis right before the baby's born, preparing the patient and her family, what the diagnosis means, what the prognosis is, what the management's going to be, and kind of what the expectation is after delivery, so that once the baby's born, it's not, a big surprise in the delivery room where everybody's hands go in the air and the baby's blue and the baby's rushed out of the room and everyone's like, what's going on? And we don't have that anymore. We're really very well prepared. And I think it just makes that whole transition from prenatal pediatrics to neonatology and pediatrics after delivery so much easier for our patients.
Are most of the babies in this prenatal diagnosis picked up, at least initially, via ultrasound?
Virtually all by ultrasound. I mean, there may be the odd patient that comes through in a different way, but most of it is prenatal ultrasound and obstetric ultrasound that recognizes the problem. There will be some patients that have had a prior affected pregnancy that might have an earlier ultrasound or a higher level ultrasound earlier in their pregnancy, so they get a more early diagnosis. But ultrasound really is the key. And if you take the whole country, we still, for congenital heart disease, and that's one of my areas of research and areas of clinical interest, we know we still only diagnose about half of all major heart defects prenatally in this country. So there's a lot of work to be done. But again, we're really fortunate in the Northeast, and particularly, in the New York area, in that, the majority of heart defects are detected prenatally. It's rare to have one, particularly one that's come through our system, that we haven't picked up prenatally. Now, there is the odd one, which the neonatologist will mention, but for the most part, we don't get those surprises, and that really, I think, helps us optimize the outcome for the baby, and again, just makes everything so much smoother for the patient and her family.
And from the point of being referred in from an ultrasound, there may be these additional steps and tests and screenings to confirm or narrow down the diagnosis, as it were.
Correct. Certainly the structural defect will usually be narrowed down depending on what the problem is, but by the people that do prenatal ultrasound, do fetal echocardiography, or radiologists that do fetal MRIs for some of our other complex anomalies. But the genetic side, that's something like, Tom is interested in, and, we have, geneticists that are specifically interested in helping the patients prenatally. And there'll be some patients that want that information prenatally, but there'll be others that will say, I'm going to wait postnatally and have Tom and his colleagues investigate once the baby's born.
Got it. So Ganga, Lynn mentioned cardiac issues here. What do you see? What are some of the more common cardiac issues that get referred into your group and into your intensive care unit there?
The most common, there are several defects that we see, but some to give you an idea of what is generally referred is something called transposition of the great arteries, and that is a very common lesion that we see, at least in our institution. That is the great vessels that come out of the ventricles are coming out of the wrong side. So the aorta comes out of the right ventricle, and the pulmonary artery comes out of the left ventricle. So this is a very complex heart defect that needs, without surgery, these babies don't survive for very long. So that's one example. The other one is when one side, one ventricle is not developed at all. So that is a hypoplastic left heart syndrome, and those babies have to go through multiple surgeries throughout their in the early part of their lives to survive. Then you have something called tetralogy of Fallot, where the right side of the heart is affected, where blood is not going into the lungs. So these are just 3 or 4 of these examples, but there are a number of other types of heart disease, almost all of which we see at our center.
Are they generally surgical issues, or are there medical ways to treat some of the children, some of the neonates you see?
Well, there are no medical ways other than, you could either, if you have a critical lesion, some of them require surgery to get out of the hospital, or require surgery at a later point. Some of them would need a catheter, transcatheter procedure. So
that's what I was thinking of along those lines. Yeah.
Yeah, so that would suffice. I'm thinking of lesions like pulmonary stenosis. That is the valve that is, the pulmonary valve is very narrowed at birth. So the catheterizer can balloon or dilate that valve, and that is all that may be required for that child's life. So you have some procedures that can be done just in the cath lab.
Things like
there's a few situations, where medical treatment might be valuable. Like if sometimes we'll identify a fetus that has a cardiac arrhythmia, and I think prenatally we try to control that with medications to the mother that gets to the baby through the placenta. But sometimes we hand our pediatricians a baby that has a really abnormal heart rate, and they have to do medical therapy and different approaches, in the intensive care to deal with that as well.
Right. That would be a case where medical therapy would be helpful. We just have to titrate the right medications, and the baby can go home after that.
Mm-hmm. Ganga, how many of the patients that are in your unit come from in-house as opposed to referred from outside?
So from the Center for Prenatal Pediatrics, almost 3 out of every 4 babies, 75% of our patients come from the center. And the remaining come from generally from the tri-state area. Many of them are the ones that come from the tri-state area. Many of them are either diagnosed prenatally but have delivered emergently in a local center, or sometimes they are just discovered because the baby doesn't look normal after birth, or they fail something called a pulse oximetry screen that we do for every newborn baby after birth, or they just happen to look very unwell after they go home. So those are babies that would need to be. Those are the babies that would get transferred to our institution.
But clearly, you're a major referral center for you don't get any easy cases, let's put it that way. They tend to be the hard ones, especially if they get referred to you from outside the hospital.
Well, there are no easy cases. We get very, very challenging cases. And I think there is some self-selection in this, in that I think the more complex cases seem to come to our center. And even over time, what we've noticed is that the cases become more and more complex than what we used to see even a few years ago.
So Donna, I want to come to you in just a minute, because we're trying to sort of follow from prenatal into intensive care. But since you follow up kind of as the children get a little bit older, let's go to Tom first, and let's talk about precision medicine, because that's kind of a buzzword these days. Tell me what that means in this context with either prenatal diagnosis or postnatal diagnosis and treatment. What does that exactly mean?
Sure. It can mean a few different things. Broadly, I'd say it means giving the right treatment to the right patient at the right time. And you can talk about that in broad categories of patients. Like, for example, children with structural anomalies of their kidneys. There's a broad disease we call CACT, congenital anomalies of the kidneys and urinary tract. It's been observed for decades that they are about 1 standard deviation lower in IQ as children. And that's been attributed to the burden of illness, missing school, being in and out of the hospital, aggressive therapies, possibly things with neurotoxic effects. But recent genetic diagnosis, looking at hundreds of these patients, if you separate those with a genetic disease and those without, the ones without a genetic disease actually have a normal IQ, whereas it's just those with genetic disease as well that have a lower IQ. So in that broad category of patients, I think I'd argue that we should be doing genetic testing sooner, recognizing and making the right genetic diagnosis, and then connecting them with services like early intervention, which can dramatically change the whole child's life. So that's precision medicine on a broad example. On a personal level, take for example a seizure disorder. So you have a newborn who is in status epilepticus without a clear insult. There wasn't an obvious hypoxic injury or an obvious infection. And now you have to start thinking about an inborn error, either something that's inherited or a de novo mutation that occurred for the first time in this child. But there's over 1,000 genes which can have variants that can lead to that presentation. And these genetic diseases can have specialized treatments. So if you can make that diagnosis quickly before there's been severe damage, you can give, say, a change in diet, a specific vitamin like B6, or a specific treatment, which can stop the seizures. And these seizures, in some of those rare cases, are refractory to our normal treatments. And then a last example I would give is in goals of care. So at Columbia, we have our comfort care program created by Elvira Paravicini, who's really a leader in this area. And these are often families who, for personal or cultural or religious reasons, termination is not an option. Sometimes providing a specific diagnosis to those families can help give them a means to understand what's going on, to let them know that this is not their fault. We can provide information to the family about the prognosis from what we know about other infants with this genetic disorder. And that can really help inform big decisions about goals of care or redirection of care. It can also help connect them with families for social support. So those are examples that I think about with precision medicine.
And it sounds like a lot of this is driven or enabled is perhaps a better word by by the technology that allows this sequencing of the genome. And as we continue to find correlations between some of these genetic variants and some of the things that show up in these babies, how has that really changed the field?
It's still changing every month. Like just 2 decades ago, you couldn't make some of these single gene disorder diagnoses. We could only do a karyotype, then a microarray. So things that look at the entire genome structurally, and we could pick out those changes. Then we could do Sanger sequencing, maybe in the more recent decades, where you can but that's picking one gene and just seeing if you're right. And then in the last decade, whole exome and whole genome sequencing have become cheaper and cheaper and more widely available. And it's not just the technology, it's also our scientific understanding, which really improves the diagnosis. So for example, most of the genetic data that we have is based on our understanding of white Europeans, because those were some of the first cases to be looked at. When you're trying to evaluate a single genetic diagnosis, you want to say how rare or common is this variant. And if you have, say, 100,000 control genomes to compare against, and you can say, wow, this variant never occurred, that makes you very excited. But if you're looking at someone from an underrepresented minority, say someone from South Asia, or pick your background around the world, we may only have a few hundred or a few of those control genomes. So we don't know if this is a common variant or not. So that's an example where it's our scientific understanding. Another technology that's changing very quickly is non-invasive prenatal screening. So taking fetal DNA circulating in a mother's blood and doing screening for that. That's only come out in the last few years. And it's now used commonly to screen for the common trisomies. But I think in the next year, we're going to see that we can extract fetal DNA and do some of these genome-wide tests that we're talking about fetally, non-invasively, and get a single gene diagnosis. So it's changing every month.
Yeah, it's actually very cool. I mean, I think, when I was having my children way back when, the focus was all on Down syndrome, and really your only option was kind of an amniocentesis halfway through your pregnancy, and you were pretty far along if you had to make any decisions based on that test. And now patients are coming in at 9-10 weeks of pregnancy and having a simple blood test and not only learning about whether their fetus is at risk for Down syndrome, but they're learning more comprehensive information. And I think, as Tom said, they're going to be able to identify many different conditions from maternal serum, so that, you know, chorionic villus sampling or amniocentesis may not be required very often in the future. So I think it's really a huge step forward for screening and diagnosing, you know, genetic conditions in pregnant women.
You know, but Lynn, I think it's going to be so challenging for you, because we're going to be getting unclear and uncertain diagnoses. And how do you counsel a mother that, well, your child is at risk for autism? These are going to be some really challenging ethical situations, as well as the art of medicine situations.
Yeah, so I think that's why, you know, our knowledge and understanding and correlating it to the phenotype and with the genotype and kind of what, you know, the long-term outcomes are, it's going to be pretty important, and it's going to be a steep learning curve, I suspect, over the next decade or so.
Max, this is where you should segue to Donna, because she's going to be giving us this information that we really need.
Exactly. It sounds like Tom and Lynn teed it up for you, Donna. There used to be, I think, that even with premature birth or some sort of complications around birth, if the child got out of the hospital seemingly intact, you thought you were in the clear. And now we're finding out that, no, there are often long-term issues here. Tell us.
Yeah, so we do see a wide range of infants who have been discharged from the NICU. So some of them are just preterm. Some of them we know have various genetic syndromes. Some are preterm and have a genetic syndrome, or have a cardiac lesion and have a genetic syndrome. It does change how we think about what is going on with the infant. Regardless of their diagnosis, though, we do standardized assessments at about 6 months of age that really gives us insight into their functioning for their cognitive skills, language skills, and motor skills. And with that information, then we are able to direct either early intervention referrals, also referrals to other specialties. So it does help us to have that genetic information, and also really helps the families for us to counsel them long-term of how we think their development's gonna progress over time.
My own daughter was considered a preemie when she was born a very long time ago.
Mm-hmm.
I think she was born at 33 weeks. Now she probably looks like a linebacker in the NICU if she were in there. We keep moving the goalpost, as it were, and are able to keep these children alive and actually get them discharged. What do you see? What are some of the things that parents in general and pediatricians need to be on the lookout for these preterm births?
I think one of the things we see early on is that a large number of them have feeding difficulties. Some of them have feeding issues when they leave the NICU, but even over the first year of life, they can have trouble transitioning to solids. They can have trouble with weight gain. That's something very common we see in all the particular populations. We also, very common for us to see expressive speech delay. So even if they're developing normally for their cognitive skills and their motor skills have improved, often they have pretty significant expressive speech delay as they get older. Those are probably the two most common things. The majority of the children we do see are doing well developmentally. You know, I think sometimes we, you know, some of the kids who have obviously been the most sick may have some more pretty significant delays, but the bulk of the children we see in clinic are going to have a good long-term outcome. And that's why we want them to come back to clinic, because we can get them enrolled in services early and really help them improve their outcomes. So I think just, you know, parents to feel that there is something we can do to help their kids, and why it's so important to come back to clinic. Not quite related to that, but I just want to say right now we are doing in-person and telemedicine visits. We could do a pretty good assessment, especially on the younger kids, and really get an idea of where they are. And then based on that assessment, we decide, do we need to have them come in and sort of the next steps. But we are able to do continue visits throughout all of the current changes in our care.
And I think you made a really important point there in that I think it used to be thought that, well, what can we do about this? We know that there may be some of these neurodevelopmental delays or even cognitive issues down the road. But I think the hopeful point here is that their early intervention can and does make a difference.
Yes, definitely. That's been shown over and over again for motor skills, language skills. Having the children enrolled early in services does definitely improve their outcomes.
One last quick question. Who qualifies for this neurodevelopmental follow-up program? What are the benchmarks, if you will?
So currently, we see all preterm infants who are less than or equal to 32 weeks. We also, for those kids, have a requirement that they're also less than 1250 grams. As we expand our clinic, we are going to be following a larger group of infants. So soon we won't have that birth weight requirement. We also see any infant who has evidence of seizures, stroke, any kind of interventricular hemorrhage, meningitis, encephalitis. Any child, regardless of gestational age, is eligible. We see a lot of our kids from our cardiac unit who have particular types of heart lesions or who have needed any sort of heart-lung bypass. And then we also follow other kids who have congenital diaphragmatic hernias, tracheostomies, other particular populations that need a little bit of extra attention.
Sounds like a very large population ultimately, no?
Yes.
At least in the group that you see in this center. Ganga, one of the questions that came in here was, is there an average length of stay for infants in the cardiac unit, or is there an age cutoff if they present after they've been discharged, for example?
So the average length of stay is, once a baby's admitted to our unit, it's about 3 weeks. Some of them, the babies with very complex heart surgery, take about 4 to 5 weeks to get out of the hospital back to where they belong with their families. In terms of in our unit, once babies go home, can they be admitted to our unit? If that is the question, then yes, we do admit patients once they are at home, and up to about 3 months. We have babies in our unit who are currently even older than that. But generally, our age group at our unit is about, young infancy, about 3 to 4 months.
Lynn, Tom mentioned that some of the things that he's able to test and diagnose may make life a little harder for you in some ways. To what extent are things that you can do pre-birth, if you will, as opposed to afterwards? I know you said that you don't want a surprise in the delivery room, but I keep hearing that we're moving more and more towards some sort of in utero interventions for some of these things. Can you talk about that?
Sure. Certainly with respect to genetics, I don't think we have too many in utero treatments yet that are going to change the outcome, but there will be some things coming. I mean, not related to congenital heart disease or structural defects, but things like sickle cell, and there's a few other conditions that we may be able to treat prenatally once we know a fetus is affected. I think where we end up doing more in utero, or at least consider in utero therapy for things like congenital heart disease, would be if we saw valvular stenosis that was quite severe in the middle part of the pregnancy, where we really thought that that valve was going to obstruct flow so that the ventricle would be underdeveloped and they really would be at a detriment after delivery. So that opening up that valve in utero may prevent the development of something like hypoplastic left heart syndrome. We do have that program at Columbia. We have not yet had to do our first case. We've done all our animal work and we're ready to go. But there are several centers across the country that will offer that for those specific cases where, you know, ballooning a valve prenatally will improve the outcome. I think the one other aspect, you know, just to keep on the theme of congenital heart disease and where there's been a lot of effort in our community is to make sure that we do diagnose those cases of transposition of the great vessels or hypoplastic left heart syndrome, particularly where with TGA, if the interventricular septum is intact, where there's no hole there to allow mixing of the blood on the right and left sides of the heart, we know those babies can get into real trouble with their oxygenation right after delivery. And if they're not delivered in a timely way with our pediatric colleagues, you know, on standby, that these babies really can get into bad trouble and die before they even get to our institution if they're born, you know, undiagnosed in a community-based hospital. And that's true for the hypoplastic left heart syndrome if there's a very restricted foraminal valley where, again, they need that to allow mixing of blood after birth. You know, having the cath team ready and the cath lab open and doing a time delivery makes all the difference in the outcome of these kids. So making the diagnosis is important, but there's a few lesions in recognizing that, you know, notifying the team, scheduling the delivery. We still allow them to have a vaginal delivery if at all possible, but we just make sure that our teams are there to deal with the baby after birth.
Mm-hmm. Tom, let's talk in some of the genetic diagnoses that you can make. Postnatally, there may or may not be that much that you can do, but how would some of those diagnoses inform future pregnancies, for example, in women?
Sure. Well, obviously, if it's made during the pregnancy, when termination is still an option, that's an important thing to consider. But for future pregnancies, you know, we have to counsel parents on what are the chances of disease recurring, and you know, what we call de novo mutations. And for that, we need to be able to sample both the parents' DNA as well as the child's. We can counsel them that it's very unlikely to recur, but because there's something called germline mosaicism, where a mother or father can have a somatic mutation that's affecting only their gonads, not the rest of their body. So you might not detect it on a blood test of the parents without doing, you know, more invasive testing. If it's a diagnosis we discover where, say, both parents are carriers of a recessive trait, then they can do pre-implantation fetus unaffected. That's an obvious example. But there's more subtle things too. For example, a lot of the genetic disorders we evaluate have what's called incomplete penetrance and incomplete expressivity, meaning not all people will be affected, and also people may be affected differently. For example, specific genes like I don't know, PAX2 or HNF1 beta can cause a variety of anomalies of the kidneys or of the heart or the pancreas or the eyes, the ears, the brain, etc. So if we find a fetus or a child with that disorder, we can then screen the rest of the family because it may help clarify what was, you know, just misunderstood as diabetes or developmental delay or deafness. It can provide important information for their medical care. It can also help us screen for problems before they arise in those people and in the patient in front of us. For example, a lot of the phenotypic manifestations of specific disorders don't arise until later in life. So we can get them connected with the subspecialists that they'll benefit from sooner and help alter the course of diseases that can come down the road.
But Tom, that's such a toughie. I mean, from my point of view as a, you know, an obstetrician and a high-risk maternal fetal medicine specialist, you know, when there's different expressivity or, you know, you could have someone with that same abnormality on their genome but functionally normally, and then have another individual that's quite devastated by the disease. Just like things like even like tuberous sclerosis, where you can have can express at different levels and different members of the same family. So then when you get that result, at least
so that's where patients and families really benefit from being in a interdisciplinary setting with genetic counselors, with MFM obstetricians, with neonatologists, neurologists, etc. All the people who can really explain what we might find and what that could mean, so that these, hopefully some of these don't overwhelm people, even though they often do, despite our best attempts.
Anna, let me bring you back in here for a second as sort of to talk a little bit about an overall picture here. One of the reasons, not the only reason, that we're doing this virtually is the elephant in the room, or the elephant across the world, which is the COVID pandemic. How has that changed what you are able to do and treat in the center?
So in terms of how we have handled the COVID pandemic at Columbia since the beginning, because unfortunately New York was, of course, part of the very first wave, and now we're having our resurgence. All critical services remained intact. And in fact, the number of patients that we cared for, both on the obstetrical side and the neonatology side, increased because Morgan Stanley Children's Hospital became the only pediatric hospital in the NYP system. And all the patients got consolidated to the one site to free up beds for our adult colleagues to use for the vast number of COVID patients that they were seeing. We had a steep learning curve. We published some of the first papers that indicated how many, unfortunately, of our moms were actually infected with COVID, but asymptomatic. And so that was a really important observation that people hadn't understood, I think, before we had that data, because we started screening all of our moms who were coming in to deliver, both for their medical care, for the protection of our staff, and for understanding the pandemic and how things were spreading. In terms of relationships with our families, it has certainly been challenging, as we've had to restrict the number of visitors that children can have. We are, like all hospitals, not built to have a pandemic where there are large numbers of people involved, and we don't have the capacity to test everybody who walks through the door. So that is probably emotionally the most challenging thing that we have dealt with from the obstetrical side and the neonatal side. I will say that our staff, in terms of nursing and social work, and our March of Dimes support people, have been phenomenal in making sure that we had new ways to engage families. We now have more than 50 iPads for the NICU where we can do virtual visits, and that has worked extremely well. And we have tried to engage families in lots of different ways, but it has, of course, changed the way we interact. Luckily now, hospitals are actually quite safe places to be during the pandemic, which sounds a little silly, but because we are very good at using our protective equipment and we have a much better sense of what we're screening for, what we're looking for, how to protect ourselves and to protect our patients and their families. In fact, community spread is much higher than it is within the hospital system. I know a lot of people are afraid of hospitals right now, understandably, but I want to reassure them that we can take care of people.
This may be a little off point, but how many of the children born to the asymptomatic COVID positive mothers were also COVID positive, and what do you do about those babies?
So luckily, it turns out that's extremely rare. So we've had one in the NYP system that we've reported. We do treat the babies as exposed, but in terms of the asymptomatic moms, we actually encourage them to have as normal an experience as possible, to care for their babies, to breastfeed their babies with appropriate hygiene. And we haven't had transmission under those circumstances. So that is really also been a change. And we decided that that was very important early on in the pandemic. And now the AAP, the American Association of Pediatrics, and ACOG also agree with us that that is the way to go, that people should still have the opportunity to breastfeed and take care of their babies. In fact, the breastfed babies do better.
I think our neonatologists and pediatric colleagues were very smart early on. I mean, I think there was a very steep learning curve, but very early in the game, I think they recognized the importance of that bonding and breastfeeding, and they came up with ways to isolate the mom and the baby, but in the same room and still allow that interaction. And I think it's really actually been a model for the rest of the country, given the data that actually you can do it safely without, putting the baby at risk. And, kudos to the team. I think we did a really good job with that.
Yeah.
Wow.
And we now have a really large cohort of moms and babies who we are following to see both what the effects are on the moms and the babies in terms of their long-term well-being, and see what support services they're going to need.
Donna, let me ask you here. I know you're following children's development here, but now we're pretty far along with a lot of moms who had congenital heart defects when they were born, and now they are of childbearing age and having their own babies. Is there something there that you counsel them, or how would you deal with that? Maybe that's better for Lynn, but I wanted to see what your take was on that.
As far as risk for development, or as far as risk for the baby having heart?
I think by the time they're adults, mostly, well, there'd be two things: whether whatever they had is something that would put their baby at risk if it was some sort of a genetic issue, but also, is it safe for them to have a baby?
I think there's probably a lot that goes into that question. Ganga can probably help here as well. And, that is a point where you might refer them for genetic testing to figure out if there is a genetic component, because certainly there are genetic diseases that may not only have mild effects on the mother. And Tom can kind of comment on that as well. I'm thinking up to George and other ones. But as far as if it's an isolated defect and if the mom is in good health, then I wouldn't expect that to have a significant effect on the baby. But if there was a genetic component, then from a developmental standpoint, we would be more concerned.
I think that's true.
As the obstetrician,
I think we often will see, pregnant patients who have undergone congenital heart or had, cardiac surgery when they were little, who are now, reaching reproductive age and are considering having their own family. And I think that genetic component's key, as Donna mentioned, just to make sure that there's not an inherited component to it. So you can at least give them that information about recurrence risk, or at least get some numbers on that. if for those cases where it's truly isolated, does not seem to be related to an underlying syndrome or genetic condition, then most women are concerned about their own health because the baby should be okay, and then how they're going to tolerate a pregnancy and a delivery. And sometimes it depends on what heart defect they had, what surgeries they underwent. I think one of the questions in the Q&A was, patients who've had a hypoplastic left heart, who've gone down multiple surgeries and Fontan, operation, how well are they doing? And that age group now is just getting into their reproductive years. We've had a couple through Columbia that have actually done okay. They are at a little higher risk for getting some fluid on the lungs and having some issues, but I think we're going to get more and more information about that subset of patients in the next 1 to 2 decades as they reach their 20s and 30s.
Got it. So I want to be respectful of everyone's time here. We've got a couple of more minutes here. We've covered an awful lot of territory. So I like to ask panelists for a take-home message, a little pearl of wisdom that we want our webinar viewers to remember from all of this. And Tom, only because on my screen you're right next to me, you get to go first, please.
Oh boy. I'm gonna put my research hat on, and I would just reflect on how much basic scientific investigations have really transformed human lives, and of the importance of continuing that effort. We spend a fraction of the amount of money on research as we do on treatment, and if we had more investments in NIH, more investment in earlier vaccine research, a lot of things could be even better. So I would encourage anyone listening to do whatever they can to push society in that direction, because we just need more of this.
I completely agree. I was trained as a basic scientist, and I'm a big fan of that. So thank you for making that point. Ganga, tell us a little bit, what do you want people to remember from your talks?
I think one has to really get a grasp on where we were about 60, 70 years ago. All babies with heart disease, they were not surviving. And here we are talking about not just survival, we're talking about trying to intervene when women are pregnant if their baby has heart disease. So trying to correct a problem. We are trying to find the genetic problems, that genetics that might have gone awry in causing the heart disease, and we want to know what happens to them, not just survival, but developmentally. How are they doing? Now that you have more adults with congenital heart disease living than you have children with heart disease. So that tells us that over time, how, survival is not just the main endpoint. These babies are really, really doing very well, becoming very important members of our society and have much to give. And now we have, these women who have had heart disease, who have had heart surgery. Now they're delivering, and we're talking about what health outcomes or problems that we have to look out for when they deliver. So I think we've seen the whole arc, and medicine is becoming. It's sometimes difficult, or we forget to see what has transpired in these past 50 years, how far we've come.
It's not just surviving, it's thriving.
Exactly.
Let me sneak one last quick question here for you from someone here asking how difficult it is to transfer someone into your unit from outside the center. You mentioned 17 beds. Do you have space for people generally, or for people, for babies?
Well, we will always make space. We will always make space. That we are not just one unit. We have. We are a larger hospital, so we can make movements within our system. It is very, very unusual for us to say no to any transfer request.
Got it. Donna, what should we remember from your discussion today?
I think the two things I want everyone to remember is that the goal of the follow-up clinic is to obviously maximize the development of all these infants, and that we have the staff and capabilities to really help the families navigate the system after the kids go home. Because sometimes the easy part for the families in the hospital, all of the care is there, but it is a lot more difficult to navigate the system once you go home. And besides developmental testing, we do a lot of case management. If families are having trouble figuring out which specialist they're supposed to go to, we actually can help with that as well. So sometimes we're seeing kids frequently for that particular issue until we get them into all the appropriate services. The other point is it's obviously good for the patient to come in, but this also gives us data that we can bring back to the units on how these kids are doing long term. And all that information helps us improve care over time. So there's really two benefits, individually to the patient, but also then getting that information back so we can use that to improve our care.
Lynn, a pearl of wisdom, please.
I don't know if it's a pearl of wisdom, but certainly I think a take home is that, we're here for you. I think those of us who work at Columbia have the benefit of the large institution, a lot of clinical programs, strong research. And I think all of us have really worked hard to develop our areas of expertise. So your highest risk patients, whether it's a pregnant woman or a newborn baby that needs services that we provide at Columbia and New York Presbyterian, we're here to help in whatever way we can. I think our community doctors and clinicians do a great job, and many patients don't require transfer in to see us. They can be managed locally, but for those highest risk patients, we're here for them, and we'll try to make those patients have the best possible experience.
Thank you. And Anna, I think Lynn stole a little of your thunder there, because I was going to say the point here is that this is really an extraordinary center with extraordinary specialties and abilities to treat really some of the toughest cases, both prenatally and postnatally.
That's absolutely true. And I think the pearl that I would leave everyone with is really the reason that I came to Columbia a little less than a year ago, just in time for COVID. I really appreciate the fact that we think about moms and babies and families from the point of conception all the way through their childhood years. And it is really an integrated system of prenatal and postnatal pediatrics. And that's very important in terms of taking the best possible care of babies and gaining new knowledge, as Tom said, and really improving outcomes.
Truly remarkable and unique. I want to thank all of our panelists tonight for a really amazing and enlightening and informative session. A reminder that the entire webinar has been recorded and will be on the, what's the official name? Columbia Children's Health YouTube channel, and all of our registrants will also be receiving a handout with the bullet points that we've talked about tonight. So please stay safe, be well, and I always finish up these days, wear a mask. Good night.
Thank you.
Thank you.
Right.